think about this for a second. You're going to take about 20,000 breaths today.
Yeah, if not more.
Right, 20,000. And unless you're meditating right now, or, maybe you just finished a sprint, you are completely ignoring every single one of them.
Oh, absolutely. Breathing it's this everyday miracle that just runs entirely in the background.
Right up until the exact moment that you can't do it.
Yeah, it's the ultimate invisible necessity. When the respiratory system works, it's completely silent. But when it fails, whether that's from a chronic disease or maybe a severe allergic reaction, it just entirely takes over your consciousness.
It becomes the only thing you can focus on.
Exactly.
So today we are going straight to the source of how medicine tackles that failure. We're doing a deep dive into a really detailed medical text.
Which is packed with information, yeah.
Unit 6, Chapter 27. And this covers the pharmacology of the entire respiratory system. We are talking about everything from asthma and COPD to those miserable seasonal allergies and that lingering cough you just can't shake. Our mission for this deep dive is to extract the most practical, surprising, and just vital knowledge from this text. We want you to understand exactly how these treatments work and what is actually happening inside your lungs.
To give you some context, asthma alone affects 20 million patients in the U.S. That results in 500,000 hospitalizations and 5,000 deaths annually.
Wow.
And COPD is even more prevalent. It affects 24 million Americans and is the fourth leading cause of preventable death in the country.
Okay, let's unpack this. Starting with asthma gives us a really clear picture of how vulnerable our airways actually are. Because the text describes asthma as basically a two-front war.
Right, it's not just one issue.
No. If we picture the airway as a hallway in a building, the first front is bronchoconstriction.
The squeezing.
Exactly. It's like the walls suddenly moving in to crush the hallway. The smooth muscles on the outside literally contract and aggressively squeeze it shut.
Which is terrifying when it happens.
But then there's the second front, which is inflammation. And that's like the floor of the hallway simultaneously flooding with thick, heavy mud. That's the mucus and the swelling of the tissue itself.
Yeah, so you've got walls closing in and mud rising.
Right. You have to push the walls back out and clean up the mud if you want any air to flow through.
What's fascinating here is getting into the underlying biology of that mud, that inflammation.
Yeah.
People tend to think of asthma strictly as the acute attacks, right?
Just the walls closing in.
Exactly, the sudden tightening. But asthma is fundamentally a chronic inflammatory disease. The inflammation, that mud in the hallway, is almost always there in the background, even when you feel fine.
Really? So it's just lurking?
Yes. And if you leave that unchecked, the text details this process called airway remodeling. Basically, the constant state of inflammation physically alters and permanently damages the architecture of the lungs over time.
Oh, wow. So the goal of treatment isn't just surviving the acute attack, it's actually stopping that long-term structural damage.
Precisely. Medical guidelines divide asthma therapy into two distinct categories. You've got reducing impairment and reducing risk.
Okay, so reducing impairment is the immediate fix.
Right, fixing the immediate problem, stopping the symptoms so a patient can, breathe, exercise, just function normally today. But reducing risk is entirely about the future. It's about preventing that progressive loss of lung function. You really have to fight both fronts simultaneously.
And because you're fighting a two-front war, your medicine cabinet requires two very different types of weapons. You have your rescuers and you have your controllers. Let's start with the rescuers.
So these are your short-acting beta-2 adrenergic agonists.
That's a mouthful.
It is, yeah. Or simply short-acting beta-2 agonists. Albuterol is the classic example everyone knows.
Yeah, the little blue inhaler. The text highlights just how fast these are. They have an onset of action between 5 and 30 minutes.
They kick in incredibly quickly.
And there's this clinical vignette in the source that really illustrates this. It describes a 12-year-old girl with a history of asthma. She's out at a riding stable, and suddenly she's in a severe crisis.
Exposure to animal dander, probably.
Yeah, likely. She's coughing, wheezing, and her respiratory rate skyrockets to 42 breaths per minute. I mean, she is in serious trouble. In that exact moment, what she needs is inhaled albuterol to rapidly relax those smooth muscles.
Right, because the albuterol is a direct-acting bronchodilator. It specifically targets the beta-2 receptors lining the lungs, and it sends this chemical signal that just forces those smooth muscles to relax.
It pushes the walls of the hallway back out.
Exactly. However, the text makes a crucial point here. Beta-2 agonists have zero anti-inflammatory effects.
Wait, none at all?
None. They do absolutely nothing about the mud on the inside. So if a patient relies only on a rescue inhaler for persistent asthma, they are completely ignoring the underlying disease.
Which is where the long-term controllers come in, the heavy hitters.
Yeah, inhaled corticosteroids, or ICS, and long-acting beta-2 agonists known as ALA. Salmeterol is a common one.
Now, I want to push back on this a bit, just looking at it logically.
Okay.
If steroids are so incredibly powerful at reducing inflammation and we have simple steroid pills, why are we always using these clunky inhalers? I mean, a pill just seems so much more efficient than carrying around a plastic spray device.
It seems more efficient until you look at the biology of how your body actually processes medication. Delivering drugs topically, meaning directly into the lungs, is a masterpiece of avoiding collateral damage.
Collateral damage? Like what?
Well, if you take a corticosteroid pill, it goes into your gut, gets absorbed into your bloodstream, passes through your liver, and then just goes everywhere in your body. It suppresses your entire immune system.
Oh, so it's not targeted at all.
Not even a little.
Yeah.
The text outlines severe systemic side effects from oral steroids, particularly adrenal suppression.
Adrenal suppression.
Yeah, where your body basically forgets how to make its own natural stress hormones because the pill is doing all the work for it.
Okay, that sounds bad. So the inhaler is a targeted strike. It keeps the medicine exactly in the lungs where it's needed.
It does, but only if it's delivered correctly. And this is a huge caveat. If you just spray an inhaler into your mouth, the propellant is moving so fast that up to 90% of the medicine just hits the back of your throat.
90%.
Yeah. It hits the throat, gets swallowed, and ends up in your stomach anyway, which brings back all those systemic side effects we were trying to avoid in the first place.
Wow, okay. So this is where the spacer comes in.
Yes, the spacer is vital.
The text has a diagram showing this large plastic tube you attach to the inhaler. You spray the medicine into the tube first, and then you inhale from the tube. And the mechanism behind it is surprisingly simple.
It's just physics, really.
Yeah, the spacer just slows down the velocity of the aerosol. The large, heavy particles of medicine just drop out of the air and stick to the inside of the plastic chamber, meaning only the smallest, finest particles remain suspended for you to breathe deep into your lungs.
It's an elegant solution. You filter out the heavy particles that would otherwise just cause side effects in your throat and stomach. And even with a spacer, the text gives a strict rule for anyone using inhaled corticosteroids.
The swish and spit.
Yes, the swish and spit. You must rinse your mouth with water and spit it out after using the inhaler.
Every single time.
Every time. If you don't, the localized immune suppression right there in your mouth can lead to an overgrowth of fungus.
Yikes.
Yeah, resulting in oropharyngeal candidiasis, commonly known as thrush.
Swish and spit. It's such a simple action to prevent a totally miserable side effect. But, as we look closer at these inhalers, here's where it gets really interesting. We aren't just dealing with human biology here. We are actually dealing with global environmental policy.
Oh, this part is fascinating.
Right. The text details the phase-out of certain inhalers simply because they were damaging the ozone layer.
Yes, this stems directly from the Montreal Protocol. For decades, metered dose inhalers used chlorofluorocarbons, or CFCs, as the propellant to shoot the medicine out of the canister.
And the text notes that to align with that global treaty to protect the ozone layer, the FDA banned those. Between 2010 and 2013, they removed 7 types of these inhalers from the U.S. market strictly to get rid of the CFCs.
Right. The goal was strictly environment.
Exactly. So they transitioned millions of patients to newer propellants, like HFAs or dry powder inhalers. It's just wild that international environmental treaties actively change the literal medical hardware a patient carries in their pocket.
If we connect this to the bigger picture, it really shows how medical treatments don't exist in a vacuum. But, an even more profound pressure on treatment comes from the patient's own DNA.
Oh, the genetics section.
Yeah, this brings us to a really critical insight in the chapter regarding genetics and asthma phenotypes.
The beta-2 receptor polymorphism.
Exactly. So we talked about long-acting beta-2 agonists, or LBAs, as key controller medications.
Right, the heavy hitters to keep the hallway open long-term.
Well, recent research demonstrates that your specific genetic makeup determines how your body responds to them. We all inherit 2 copies of a gene for this specific lung receptor.
Okay, one from each parent.
Right. If you inherit 2 copies that code for the amino acid glycine, the medication works perfectly as intended.
So far, so good.
But if you inherit 2 copies that code for the amino acid arginine, what geneticists call being homozygous for arginine, the biological response changes entirely.
And according to the text, About 16 to 20% of the population has that specific homozygous arginine trait. So for a fifth of the people out there, this standard, highly prescribed therapy might actually be dangerous.
Yes. The text explicitly says they may be at risk for worsening symptoms with long-acting beta-agonist therapy.
Wait, taking the medicine meant to control their asthma could trigger a crisis?
It could. It's a massive paradigm shift. It means we cannot just practice blanket medicine anymore.
That is mind-blowing.
The text advises clinicians that because we don't routinely do population-based genetic testing yet, they have to carefully monitor any patient starting a LABA. If the patient gets worse, the drug must be discontinued immediately.
So if a medication is making things worse, it might not be that your disease is progressing. It might literally be that your genetics are fundamentally rejecting the mechanism of the drug.
Exactly. It's a perfect example of personalized medicine. Your specific genetic code dictates if a widely prescribed inhaler will keep you out of the hospital or, put you in it.
Wow. Okay, so if asthma is about managing reversible inflammation and constriction, what do we do when the damage isn't reversible?
That's the hard pivot.
Yeah, the text transitions here to COPD, chronic obstructive pulmonary disease.
COPD is a completely different mechanism, even though it shares symptoms with asthma, like shortness of breath.
Right, the outward experience is similar.
But COPD encompasses emphysema and chronic bronchitis. And unlike asthma, which, can be triggered by allergies or exercise, COPD is overwhelmingly linked to smoking or severe environmental exposure.
The text is very clear on that link.
The toxic exposure physically destroys the lung tissue over time. With emphysema, the tiny air sacs in your lungs, the alveoli, they lose their elasticity.
So they can't bounce back.
Exactly. Think of a balloon that has been inflated and deflated too many times. It just gets floppy and it can't push the air back out.
And this leads to a progressive decline in what the text calls FEV1, or forced expiratory volume in 1 second.
Basically, it's a measure of how much air you can forcefully blow out of your lungs in exactly 1 second.
So as COPD progresses, that capacity just keeps dropping.
It just steadily declines, yeah.
Now, I have a question about the treatment here. If beta-2 agonists like albuterol are the absolute stars of opening up asthma airways, why does the text pivot to a completely different class of drugs for COPD? I mean, why wouldn't albuterol work just as well here?
Because the underlying pathophysiology is just fundamentally different.
How so?
Well, in asthma, the primary issue is smooth muscle constriction, right? The belt tightening.
Right.
In COPD, you have permanent structural degradation and massive mucus hypersecretion. Because of this, the foundation of therapy shifts away from targeting beta-2 receptors and moves toward anticholinergic agents.
Anticholinergic agents like ipratropium.
Exactly, ipratropium.
How do those work differently than the beta agonists?
They target a completely different nervous system pathway. Anticholinergics actually block the vagus nerve.
The vagus nerve?
Yeah, it's basically a communication highway from your brain to your organs. And in COPD, this pathway is overactive. It's constantly telling the lungs to stay mildly constricted and to just produce excess mucus.
So it's a faulty signal.
Right. By blocking that specific signal, you significantly reduce the mucus secretion and relax the airway.
Okay, what about steroids then? If the lungs are damaged and inflamed from smoking, wouldn't inhaled steroids be a primary defense? Just like they are in asthma.
You would think so, logically, but their role in COPD is actually severely limited.
Really?
Yeah. In asthma, inhaled corticosteroids are the first line of defense. In COPD, they are restricted only to severe cases, usually where the patient's FEV1 drops below 50% of what it should normally be.
Why limit them so much if there's inflammation?
Because they don't alter the trajectory of the disease. The text is very clear on this. Inhaled corticosteroids do not impact the progressive structural decline of lung function in COPD.
They don't stop the damage.
No, they might offer some symptom relief, maybe reduce flare-ups, but you are not stopping the lung collapse.
That's sobering.
There is a case study in the text about this. It's a 68-year-old retired police officer who smoked half a pack a day for 40 years.
Classic presentation.
Right. He has mild intermittent COPD, his initial therapy. It's just a short-acting bronchodilator as needed.
No steroids.
Exactly. You don't throw systemic steroids at him because the toxicity outweighs the benefit, and you don't start with heavy daily controllers if his symptoms are mild.
So what's the most important intervention for him?
The absolute first step, regardless of the stage of COPD, is smoking cessation. You have to stop adding fuel to the fire.
That makes total sense.
Sure.
Okay, we've been talking about major chronic diseases, these life and death struggles of asthma and COPD. but the lungs also have to deal with everyday invaders.
Smaller battles, yeah.
Let's look at the stuff that sends people wandering down the pharmacy aisle. Allergic rhinitis and that stubborn, dry cough.
The everyday nuisances that can just drastically decrease your quality of life.
So what does this all mean when you are standing in the allergy aisle looking at a wall of boxes?
Yeah.
What you are actually trying to buy is a way to stop mast cell degranulation.
Which is a very clinical term for a very irritating process.
Exactly. So here's how the text breaks it down. Your body encounters an antigen, like pollen, dust, maybe pet dander.
Right, the trigger.
During your first exposure,
Yeah.
your body produces specific antibodies called IgE. Think of IgE as molecular wanted posters.
I like that analogy.
They attach themselves to mast cells in your nasal tissues. So now you are sensitized. The trap is essentially set.
Then the next time you breathe in that specific pollen, the pollen binds directly to those IgE wanted posters on the mast cell.
And boom.
Boom.
Wow.
That triggers the cell to literally degranulate. It bursts open, dumping potent chemical mediators, primarily histamine, directly into your tissue.
And histamine is what causes the local chaos, right?
Oh, yeah.
The mucosal thickening, the watery eyes, the sneezing. It's just a localized inflammatory explosion.
So to fight it, we use antihistamines.
But wait, if antihistamines are supposed to target the tissue in my nose, why do the older first-generation ones like diphenhydramine make me feel like I need a 12-hour nap?
Ah, that has to do with the blood-brain barrier. First-generation antihistamines are small, fat-soluble molecules.
Meaning they can travel easily?
Yes, they easily cross from your bloodstream right into your brain. And in the brain, histamine actually functions as a neurotransmitter that keeps you awake and alert.
Oh, so by blocking histamine in the brain, you're blocking your wakefulness pathway.
Exactly. You cure the sneeze, but you knock yourself out in the process.
Which is why people generally prefer second-generation antihistamines, the boxes you see everywhere, like Claritin or Zyrtec.
Right. Those molecules were specifically engineered to be larger and less fat-soluble.
So they can't get into the brain.
Exactly. They cannot cross the blood-brain barrier effectively. They just stay in your peripheral tissues, your nose, your eyes, your skin, blocking the allergic reaction without putting you to sleep.
But there's a massive warning in the text regarding a different type of allergy medicine. Not the pills, but the over-the-counter nasal decongestants, the nasal sprays.
This raises an important question about self-medication. You're talking about the short-acting alpha-adrenergic agonists.
Right. The most common brand name people know is Afrin, which uses an active ingredient like oxymetazoline or phenylephrine.
So when you have severe nasal congestion, your blood vessels are inflamed and swollen. These sprays work by violently constricting those dilated blood vessels in your nasal mucosa.
They just force them shut.
They shrink the swollen tissue, and literally within minutes, you can breathe perfectly.
But the textbook explicitly warns that these alpha-adrenergic nasal formulations should be used for no longer than 3 days.
It is a very strict rule.
So what happens on day 4? Why is it so strict?
If you use them longer than 3 days, you risk a condition called rhinitis medicamentosa.
Which is?
It's a severe form of rebound congestion.
How does that happen biologically? Like, why does it backfire?
Your body is always trying to maintain balance, or homeostasis. When you constantly flood those nasal receptors with a constricting drug day after day, your body responds by downregulating its own natural receptors.
So just assumes the drug is going to do the work.
It essentially becomes dependent on the nasal spray just to maintain normal vessel tone. So when the drug wears off, the vessels lack the normal receptors to stay constricted.
Oh, no.
Yeah, they dilate massively, and the congestion comes back entirely worse than before you ever used the spray.
So patients end up trapped.
They get trapped in a cycle, needing the spray every few hours just to establish a baseline, causing more and more damage to the tissue.
3 days. That is a hard limit every listener needs to respect. Step away from the Afrin after 72 hours.
Absolutely.
Okay, so we've talked about how the lungs deal with inflammation and structural damage. But there's another respiratory defense mechanism that doesn't actually happen in the lungs at all.
Right, it happens in the brain. A cough is an important defensive response to clear the airway. But a non-productive, dry, chronic cough serves no biological purpose. It's just exhausting.
Just ruins your sleep.
Yeah. The text contrasts 2 major drugs used for cough suppression, codeine and dextromethorphan. It's actually a fascinating look at how pharmacology isolates specific biological effects.
Right, so codeine has historically been the gold standard for cough suppression. It works centrally, meaning it crosses into the brain, and decreases the sensitivity of the cough centers to peripheral stimuli.
It basically turns down the volume on the cough reflex.
But codeine is an opioid. It's a morphine derivative.
Exactly. And even though it suppresses a cough at lower doses than are required for pain relief, it still binds to the mu-opioid receptors in the central nervous system.
And that brings baggage.
A lot of baggage. Because of that binding, it carries the classic opioid side effects: constipation, dysphoria, fatigue, and crucially, addictive potential.
Enter dextromethorphan, or DM. This is the stuff in almost every over-the-counter cough syrup today, like Robitussin DM or Delsym.
The modern solution.
The text explains it is also a synthetic derivative of morphine. But wait, if it's derived from morphine, how does it bypass all the opioid side effects? Why isn't it addictive?
It all comes down to the physical shape of the molecule. Dextromethorphan is what chemists call an enantiomer.
Enantiomer?
Yes, it is a molecular mirror image of an opioid. Imagine your left and right hands. They are identical in structure, but you can't put a right-handed glove on your left hand.
Oh, that makes perfect sense.
Because dextromethorphan is a mirror image, it does not fit into the mu-opioid receptor glove that causes pain relief and addiction.
It just bounces off.
Right. However, it does fit perfectly into different receptors in the brain, specifically sigma receptors that control the cough threshold.
So it suppresses the central cough center just as effectively as codeine, but because its 3D shape is reversed, it simply avoids the pain and addiction receptors entirely.
Exactly. It has absolutely no analgesic or pain-killing effects. It's a perfect example of isolating the exact therapeutic benefit you want while stripping away the heavy baggage.
That is incredible. Just flipping the geometry of a molecule changes it from a highly addictive narcotic to a safe, over-the-counter cough syrup you can buy at the grocery store.
Pharmacology is wild like that.
It really is. Well, we have covered a massive amount of ground today.
You certainly have.
To summarize the practical takeaways for you listening, if you are using an inhaled steroid, advocate for a spacer. It uses basic physics to drop the heavy particles out of the air, getting the medicine into your lungs and keeping it out of your stomach.
Crucial step.
Always swish and spit after using those steroids to avoid thrush. Understand that if COPD is progressing, the medical focus shifts to anticholinergics to fight structural damage, rather than just treating inflammation.
Right.
And for the love of your nasal passages, stop using over-the-counter nasal decongestant sprays after 72 hours to avoid severe rebound congestion.
Those are the practical, everyday applications, and they are incredibly important. But I want to leave you with a broader thought, sort of returning to that genetic asthma discovery we discussed earlier.
The arginine polymorphism.
Yes. We learned that a widely used medication, long-acting beta agonists, could actually worsen the condition for up to 20% of people simply because they possess a tiny genetic variation.
Just a slight difference in their DNA.
Exactly. As we move deeper into the age of pharmacogenomics and personalized medicine, it begs an unsettling question. How many other standard treatments, things currently sitting in our medicine cabinets right now, are completely mismatched for our unique genetic code, just waiting for science to catch up?
That is a profound question and honestly a perfect place to leave it. Thank you for joining us on this deep dive. Take a deep breath, appreciate the complex machinery making it happen, and we will catch you on the next one.